Hi, everyone. I'm Ted Burton, and welcome to this Central Health webcast, Data 101. It may not be the most provocative topic, but it is a very important topic. If you were to ask 10 people to give us a definition of data, what would that definition be? I'm going to put some folks on the spot. Rachel, how would you define, first of all, is it data or data?
I say data.
I say potato. So how would you describe, what is data?
I would describe data as a collection of information that we pull from different sources to use to better improve systems.
Good, it's great. Mary, can I ask you? No? Come on, how would you describe, what's data? Define data.
I guess generally I'd say data is information, and it can be a variety of things, so it's really important to define what it is.
That's a great answer. So we have a panel of experts. I'm going to turn it over to Mike Geeslin, our president and CEO, to talk a little bit more about who we have and what some of the ground rules are for today. Mike?
Right. Thank you, Ted. So, obviously the topic is data, and there's different ways to describe it, as you all know, and there's also many different types of data, but also it's the systems behind it and the people behind it, and ultimately what the end result is. And so through this conversation today, we hope to be able to cover that waterfront. Fortunately, here with us today, Ted said there were experts here. There's actually two experts here, not three. We have John Clark, Central Health's Chief Information Officer, and Sandy Simmons, who is Central Health's Director for IT and Enterprise Services. So welcome to both of you. Thank you for being here. Thank you. So as far as the ground rules, we have some questions back and forth, but we want the conversation to be informative. And so if there's something that we're not asking or something that we need to elaborate on and go deeper on, by all means, take us there, because, again, at the end of the day, we all want a good understanding about data and the systems and the uses. So first, I'll open it up to Sandy. You could start creating different buckets of data. There's demographic data, there's encounter data, laboratory results, prescriptions. You can do counts of people. So just talk to us a little bit about the types of healthcare data that we're dealing with right now.
Sure. So I've worked in safety net healthcare data for over 20 years, and over those 20 years, the type of data has changed, and the amount and the volume of data that's available now is far more extensive than it was 20-some years ago when I was first starting out. As you mentioned, there are lots of different types of data and if you go to the doctor, if I go to the doctor, they have you fill out a standard types of forms, and they want to collect certain basic information about your demographic profile. And then during the visit, there are certain procedures and services that are provided to you, and all of those relate to certain types of codes that they collect. And then our insurance companies or our providers have certain billing information and codes that they then submit to providers. So data can, the types of healthcare data certainly are varied, and traditionally it's been those types of demographic diagnosis, procedure codes that are related to treatment and billing. And now, lately, we're getting into more a broader range of data, things like your social determinants of health data, where what are your living situation? What's your living situation like? Do you have food insecurity? Do you have?
These are examples of social determinants.
Those are types of different data that are expanding in the healthcare arena, especially that are important to help, that can help providers, be able to diagnose you, and ultimately, in the long run, will help us to serve our patients better, I think.
Is the way data is collected and analyzed consistent across the industry?
Well, yes and no. I think, certainly payers collect certain types of billing data and claims data. There are standards in claims data that in order for a claim to be processed, they require certain types of information to be captured on a claim form, and that is processed consistently. But it depends on, certain payers. The federal government wants data collected certain ways. United Way, as a funder of certain organizations, wants data collected certain ways. Robert Wood Johnson Foundation might want data captured and collected and reported in different ways. So there can be some subtleties in the way data are captured.
So when you look at the types of systems to be able to handle all this data, whether it's demographic data or patient data, John, talk about some of the architecture around what's needed to capture this.
Sure. There's extensive database work that has to be done in order to capture data. A lot of times it relies heavily on what the front-end systems are, where you're either engaging with the patient or engaging at the financial level or different aspects. So in general, you're really relying on the source systems of the data as it's feeding data into the repository for whatever you're trying to accomplish.
So break that down, like at the point of service. What would be something that we could identify, like at the counter where you capture data?
So in a clinical setting, when a patient is registered, they're registered through what is considered an enterprise practice management solution, or some people might hear it as an EPM. That's where you're capturing all of the demographic information, the information on the patient's home and different things, and actually acknowledging that they have arrived for their appointment. And also on the back end of that, you're capturing various informations like their insurance information and different things of that nature. Those are traditionally used inside of a clinic for specific decision making at that clinic. When you start getting into a more enterprise approach, you have to have a framework for accepting that level of detail from multiple sources. For example, inside of Central Health, we have various partner organizations that are actually contributing that demographic data into our environment, and we're storing that data, both historical and current data, in an enterprise data warehouse. That helps to inform decision making at the Central Health level, and also provides a framework by which we're able to do some population management on those patients.
So you used an interesting term, enterprise data warehouse. Where is this warehouse, and what are the hours of operation?
Actually, that's an interesting
It's
question.
next to the
Mike.
iCloud, right?
So the cloud,
Yeah.
or up in
So-
the cloud.
The infrastructure aspects of a data warehouse never cease operations. So we actually have our data stored at a off-site cloud storage facility. They actually administer all of our server capability as well as our storage capability. And that organization, with terabytes and terabytes of data that we have in our storing, it's secured storage. It's operational 24/7. So if we were, anyone were to log in to any computer within the enterprise at a given time and had the appropriate
So
access.
this could be at a clinic, for example.
At a clinic, if they had appropriate access to the various levels of the data, they would be able to access that data.
Well, so can you summarize then for medical records or for data, where does it come from and how is it used?
Hospitals and clinics utilize a tool, electronic medical record or electronic health record. These tools are generally used for the collection of results, testing. Their physicians and practitioners are able to utilize those tools to place orders on the patients. A traditional medical record would house progress notes on the patients, various things.
And in the olden days, those were
Paper.
manila or files,
They were
paper files.
Yep. You walk into a clinic and you just see walls and
Right.
walls of charts of patient records, right? And so now all of those charts are actually held inside of electronic medical record. The data is not always as discrete as you may want it in those electronic medical records.
What do you mean by that? Like as secure?
No. So different EMRs have different capabilities of controlling what data elements are actually either able to be inputted directly or that have table files that are built behind it that are like selection criteria, like they use selection criteria for a data element.
So it's not open-ended?
It's not
There's some
open-ended.
controls and security around it.
So when you talk about discrete data, you're talking about these ones that are not open-ended. Non-discrete data is things where you can just type away, or you can change the format or that type of stuff. So you can think about it from this perspective. If I have a notebook and I'm writing in a notebook, I can write anything that I want. But if I have flashcards in front of me that already have a word written on them, and I need to find one word out of a stack of flashcards, I can go to that flashcard and say, that's the word I want to use. That's kind of the difference between discrete and non-discrete.
Structured and unstructured data is another term that people often use for that.
So something that we talk a lot about and we hear people really asking for is the sharing of these files among providers, correct? Can you talk about how we're moving towards that, so providers are collaborating more, and which is better for the patient in the long run?
Sure, I'll start and then I'll let Sandy kind of jump into a little bit. So in general, every organization needs to have their own set of data. There's an importance to that because there's a population of patients that every organization and every clinic has specific to their environment. So it's crucial for them to be able to manage that patient at that level. But it also is important to understand that that patient has the ability to hit multiple entry points within the rest of the region, the rest of, even nationally. So what's important about, let's say, central health data specifically, is not the same importance as it would be for, say one of the other partner organizations, and they all have their own data repositories. We utilize that data in these individual pockets for the specific business intelligence within those environments directly. Where you end up needing to share this data is around more of the population management, the real utilization of patients within the environment, understanding all of their transition across the different environments. So a good example might be that in our patient population, patients are part of the MAP program, and then they may fall out of the MAP program and get private insurance, become employed, get insurance, and then at some point come back into the MAP program. For the period of time that they are not inside of the MAP program and they're in a private insurance company, we would not have record of that in our own business intelligence.
And you're referencing the MAP program. That's our medical assistance program, which is our primary care program for the individuals that we serve.
Yep.
And I was just say, so approximately 20 years ago, it was even more of a problem than it is today, but because we had more uninsured in the state of Texas, and the safety net providers in this community brought themselves together and said, we have an issue. The number of uninsured is only continuing to grow. And Seton had an idea of how many uninsured they were seeing, and St. David's had an idea, and community care clinics had an idea, but nobody really knew the number of people that were hitting all of these systems. So we created the ICC, the Integrated Care Collaboration, which was one of the first, it was the first regional health information exchange in the state of Texas. And the point of that organization was to pull all of this data on folks who didn't have a single primary care medical home and who were hitting the safety net system in multiple locations. And pull all that information together and allowed the providers then to have feedback on the patient that is being seen for diabetes at El Buen was also being treated at Peoples for something else, or was then seen in the emergency room at Brackenridge or South Austin the night before. And those doctors who were treating that patient at El Buen really needed to have access to that information. Or there were patients who were asthmatic who were hitting the ER at Seton. And Seton had a asthma education program. So people who were not connected to a primary medical home but we're utilizing a Seton facility, we're then able to be contacted and redirected to a Seton program that could help them treat their asthma in an outpatient, a more appropriate setting than the emergency room. So there's ways that pulling data across the community can really help providers have a more complete picture, again, of the patient and help them get access to the most appropriate place for them to receive care.
And improve the patient's
and improve
lives.
and reduce the duplication of effort across the safety net, because there are limited dollars available in the community to treat patients, and as the number of patients was going up and the number of dollars then becomes fewer and fewer, you need to utilize those dollars appropriately. And so,
I think one thing to kind of highlight on what Sandy is talking about, there are different tools and different ways to utilize data for the various degrees at which we try to get to data. So Sandy is talking about this collaboration that happened some number of years ago. There have been several.
And when was that? Again, I'm sorry.
so it was formed the organization was formed in '97, and we started sharing data in 2002. And the organization still exists today.
So we're really on a 15-year journey up to this point.
Right.
That's correct.
Just to put that into perspective.
Yeah.
That was great.
And so there are various tools that you use to get to this data. Traditionally speaking, a health information exchange, which is really kind of an odd way of describing it because it's really a medical record exchange, gives the ability for individuals, providers, to access patients' records at the point of care. That is a crucial tool whenever you have patients who are moving around throughout the environment, so that the physician can see the treatment levels at every different stage of their care in your environment. So with a traditional HIE, health information exchange, it's important to point out that those tools are somewhat morphing into something different. And at the community level, it's morphing into a tool that can be used not only for the medical record aspects and just being able to get to the clinical information, it's how these other things like the social determinants of health actually interact with that patient's care, and vice versa, and then how you utilize this new approach to a health information exchange versus just a medical record exchange to guide you in that patient's treatment as they're sitting there with you.
And it's interesting to hear you both talk about this, and it really raises the question, this seems so common sense. Like, why not have systems that talk to each other and let providers working in hospitals and clinics have the same information in real time? Why does it seem so much easier said than done?
So just a little bit for me on that. I mean, I think that every organization struggles with a couple of different things. There are very strict regulations around data sharing that are federal mandates, as well as state and local rules around the sharing. So you have to go through various iterations from a legal perspective to create the arrangements or the relationships between organizations in order to share this type of information. Traditionally, you can use or share patient information for treatment, for payment, for operations. And so you usually have these three different areas that you can openly share patient information. When you start talking about the framework of being able to share it for analytics purposes or being able to share it for these bigger picture items.
But you would use it like a management or a planning level.
Planning, yeah. So if you start getting into the research of the data across multiple organizations, it changes the dynamic. So that's one aspect. I think another big aspect is in most communities there are significant trust factors that have to be overcome. So you do have various organizations that are competing for the interest in the same patient, and so being able to understand how to create a collaboration with those business partners and say have them come together and create one conversation around data is sometimes a little complex. And so there are work efforts going on today within Austin and the entire Travis County area to bring these various organizations together. But again, it's really the nature of getting past the legal hurdles and some of the trust factors.
And the individual needs to factor into this as well at some point, right? I think initially when we were starting out, the patient, right, didn't have there wasn't a lot of thought around where your medical information was going, but as systems got more sophisticated and hackers got more sophisticated and people started having medical records hacked and their information shared without their consent, that became more and more of a problem. And so ultimately, I think the individuals and the patients now should have a little bit more say and control over where their information is going. And I do think that's the direction we will ultimately go. People will give consent.
And that could be a topic for a whole webcast on just
right.
data breach and security,
Right.
correct? I mean, I don't know if we want to get into it now, but that would be, I think that's top of mind for everybody.
Right.
I want to pause and see if anybody in the audience has any questions so far about what you've heard. Anybody? Monica?
A few minutes ago, when you guys were talking about the types of medical information that's collected or medical data, you had made a distinction between discrete data and unstructured data. And the one seems like it's more like the free text, and one, there are more rules about the information that's included. Why do we care?
So in general, whenever you are trying to utilize data for analytics purposes, it's a lot easier to do that whenever you have very discrete or standardized data elements, right? So if you might think of it from this perspective. If I give you a paragraph or 1,000 paragraphs of information from 1,000 different patients, and all you're looking for is one key word out of those paragraphs, that is very complicated to do whenever you're trying to analyze the data. Whereas if there was just one word that was always the same on every single patient, that's a lot easier to count, right? So traditionally speaking, when you're talking about just the basics of analytics, you're talking about yes and no answer, right? Or a 1 or a 0. And so when you think about it from that perspective, you can calculate the yes and no answers on discrete data, but on massive amount of data that is non-discrete, you cannot do that. It's very unstructured. Even whenever you have data elements that are unstructured, and there's only one, you can only put in one word. There's only enough space to put in one word. If I can type 50 different ways my name into a box, and then you want to look up how many times a person named John came into your environment, you would have to actually build the back-end analytics and the algorithms to account for all 50 responses.
Darlene, you have a question?
Yeah, I'd like to get a sense of who's using the data and accessing the information, and what can we do? I mean, can every nurse and doctor in the system go into the warehouse and have all that information to actually be able to help the patient?
So in our environment today, access to this data is somewhat restricted, all right? It's very restricted, actually. So for various levels of data, Central Health, with its partnership with Community Care, maintains Community Care's database environments. That is outside of the scope of the Enterprise Data Warehouse, which is governed by the Community Care Collaborative. So if you think about it from the Community Care perspective, they have analysts with very specific security rights and very specific access controls to that data. And so only those analysts are able to get to that level of disaggregated or non-aggregated data, right? And so they then would be building reports based on questions that Community Care was specifically asking about that data. Inside of our data warehouse, only a handful of people can actually access that data who have specific rights and responsibilities to that data, and build the reports or the structured aggregated data sets that they're looking for. Now, each one of these organizations also have a very strict process by which other people can actually request data and go through the process of understanding their business relationship and our clinical relationship and figure out whether or not they actually have any reason for accessing that data. If those things go through that process and are accepted by executives as well as our legal counsel and various other people, then reports can be generated and given to those people.
And people who are accessing data on a daily basis at the clinics or in the data warehouse are trained every year. They go through a process where they are trained and tested on their HIPAA knowledge and skills on an annual basis. So that is a requirement as well.
So I think this really comes down to the patient experience, because that's what we're really trying to improve and help our community
Right.
get healthier and live stronger and better. So could you, or either one of you, talk about the patient experience? So if you're a patient at community care, how is this data being used right now? And do you see any areas for improvement, big changes on the horizon that we're working towards?
So I know a little bit about what happens now when you're seen at one of the clinics. Your information is captured.
So you walk in, you have an
You walk
appointment or
in,
not
right.
to see a provider.
If you've never been in there, been seen before, and you're not currently on any insurance plan, they might take you through a process for screening initially, and we have tools available to see, do you qualify for Medicaid? Do you qualify for the exchange? Do you qualify for one of our local programs, MAP or sliding fee scale? And so there is information that is captured in that regard or related to your eligibility. When you're seen in the clinic, they again have your basic demographic information, and they'll capture whatever services are done. That information is used then and aggregated at the clinic and the provider level, because the providers all have what's known as a provider panel of the patients that they see. So they have, your doctor has you on their panel, my doctor has me on their panel. And the doctors need to keep up with, have my patients had all of their immunizations? Are they up to date on their blood tests? Are they up to date with the standards of care? So those types of data are aggregated into reports and or dashboards, and we're working with the clinic analytics staff to help them have ways to produce those dashboards on an easier and a more efficient way for the providers, so they have more real-time information access to that data. But it's, again, all contained within the system to help the providers make sure their patients are getting the best care possible.
And so right now, if you're a patient at community care, but then you have to go to the ER, the emergency department, can the ER doctor easily and quickly pull up the records from community care now as it stands?
So not directly they don't tap directly from the ER into community care's record. They could go through, for example, the health information exchange and access the patients. If the patient has consented, the ER physician could log into that system and see a summary of that patient's information and have that kind of longitudinal information available to them. And again, on the community care side, then, when that patient has that visit, what we're working on and what's soon going to take place is that ER visit data is going to feed back to the community care electronic medical records. So they'll have that, so the provider will then know, hey, my patient was in the emergency room last night. So all of those systems are in progress.
And it's interesting to hear the two of you talk, because you have these words and this jargon that you use, and we've had to define some of that along the way. But how do you all talk to each other when you're not talking to two non-technology people? Would we understand the language? I mean,
There's a lot of letters.
Yeah, it probably sound like quite a different language to you if you heard us on a day in and day out basis. But,
It's geek speak.
Okay. Which is we are in favor of that. So, but as a non-technologist and a patient, I mean, what's one question you ask your provider as they're, it could be at the front desk, it could be in the exam room, as they're on a computer or a tablet, what would you as a patient want to ask?
Specifically about the data?
Sure.
I mean, I think that for me and for most patients probably, they're really going to be interested in understanding how their data is going to be utilized. I think that for the most part, if I ask the question to the physician of how my data is going to be utilized, and the response is you know, for your treatment here and in other organizations that you may have to go visit for your medical care, and they explain to me the value in that. You know, with a traditional health information exchange, and what I described a while ago as being a medical record exchange, physicians in a subsequent visit in a different facility, if I know that they're going to be able to access my patient information from my primary care doc, let's say, and I'm in the ED and not able to speak for myself, that gives me a huge comfort level, knowing that my primary care doctor has already listed all the medications that I'm on, all of the diagnoses that I've had, so that the ER doc is not having to make guesses.
And I think that's key to it. So whatever you ask as a patient, you have to be 100% comfortable, because at the end of the day, it's your health.
Right.
That's right.
I always ask, what EMR system are they using? Do they like it? I watch and make sure that.
I bet you're a tough patient.
I do.
Patient. And good for you.
We're going to wrap up, but in the next 5 to 10 years, what will be the biggest thing coming down the pike when it comes to information technology, medical records? I mean, if you're thinking big and bold for the future, what do you hope to see, or what do you expect to see?
There is a very big push in our industry today with this thing out there called big data, and it's actually taking even a more broader approach, but being able to do very, very deep dive analytics on historical, I guess, research and data that's been provided through various studies. I think that is one thing. I think that there's going to be a huge movement, and I could be way off on this, but it's my guess, right? There's going to be a huge movement in the ability of data systems calculating specific outcomes for patients with various diagnoses, various social histories, different things of that nature, and really providing some level of guidance to providers to how they should go about a course of treatment for a patient. And I think that right now we have rudimentary approaches to being able to do that, but I think as in the next probably 10 years or so, we're going to see vast amounts of changes in that area.
I also think there's going to be a lot of mobile technology. A lot of people keeping their own medical records on their phones.
More
perhaps.
so than what we have today.
More so than what we have today. I think there's a push to keep people out of hospitals and out of clinics and keep them in their homes. And so whether that's remote patient monitoring systems or mobile check-in and video conferencing and all of those things, it's going to, I think, mobile's a big.
Means security is going to always.
It's always going to be.
Only going to get more and more important.
So there's our topic for Data 102.
Exactly. Data 102.
Well, this has been a great discussion, and I just have some last rapid-fire questions, and so I'll give you two options, and don't overthink it. Just answer as fast as you can. Sandy, we'll start with you. So, Apple or PC?
Apple.
John, Apple or orange?
I'll go with the orange.
Okay. Dallas Cowboys or Houston Texans?
This is getting really dangerous, actually.
Can I say neither?
Sure.
Neither. The Bears. Sorry.
Health Central or Central Health?
Central Health.
All right, very good. Ladies and gentlemen, please give John and Sandy a round of applause. You've enlightened us, you've entertained us, you taught us, and we thank you very much. And for those of you watching, we hope that you've appreciated this conversation as well. On behalf of Central Health, thank you.